I wish you all a very good day from no matter what part of the globe you are joining our fantastic webinar, which is titled Pharmacists Supporting Men with Erectile Dysfunction, a People-Centered Approach to Care. I also want to have a very warm welcome to those people around the world who will be listening in after the live event. And I want to welcome warmly our guests who I will shortly introduce. Erectile dysfunction is a common condition that has a significant impact on the quality of life of those affected. Pharmacists have a key role to play in supporting people with erectile dysfunction by providing evidence-based guidance on pharmacological and non-pharmacological management and promoting self-care strategies. During this webinar, FIP will launch a new publication titled Erectile Dysfunction, a handbook for pharmacists on managing symptoms and supporting self-care, which provides insights into the latest approaches to ED management. Expert-led presentations will provide participants with valuable knowledge on assessment, treatment options, and best practices for pharmacy-based interventions. My name is Daragh Connolly, and I am a community pharmacist from the Republic of Ireland. My involvement with FIP stems from my membership of the community pharmacy section through the Irish Pharmacy Union, and I now have the great honour of chairing the Board of Pharmaceutical Practice at FIP. Very briefly, the Board of Pharmaceutical Practice brings together different areas of pharmaceutical practice and pharmaceutical science and pharmaceutical education to work on exactly the type of projects we are showcasing today around erectile dysfunction and around self-care. So it's my great honor to moderate this with such a talented panel of people who have contributed. If I may, firstly, we need to consider a little bit of housekeeping. So if I may say, you can see on this slide, we have some announcements. Please note that this event will be recorded, live streamed on FIP YouTube, and a recording will be available at events.fip.org. To all those listening, please feel free to send your questions through the question and answer box provided, and I will do my very best to manage all the questions so that at the end, we will be able to address those questions. You are welcome to provide feedback to webinars@fip.org. I would also like to take this opportunity to promote the benefits of membership of FIP, including events and webinars. FIP is the global body representing over 4 million pharmacists and pharmaceutical scientists. If you are a pharmacist or a pharmaceutical scientist and you would like to become a member, please register on FIP's website at fip.org. I'm also delighted that we have the ability, through a new translation feature on Zoom, that people whose first language may not be English can also join us. And I'd also take the opportunity to thank everybody who is giving greetings and salutations from around the world in the chat boxes. The first few that I saw were from Ghana, from India, from Bulgaria. So colleagues, be you a pharmacist or a pharmaceutical scientist, you are most welcome. At FIP, we work hand in hand with people who are pharmaceutical scientists and pharmacists who have a particular interest in advancing patient care. And one of those who have helped us greatly to make this webinar possible today is a company called Opella. And I want to thank them for supporting us with unrestricted funding. We have a fantastic lineup of speakers today, ladies and gentlemen. And I want to sincerely thank each of them, not just for their time and effort that they are going to share their expertise with us today, but the time and effort that they have put into their presentations, and also the time and effort that they have put in with the team at FIP in making the handbook such a fantastic reference for pharmacists and pharmaceutical scientists. I will get to each of them and their proper introductions as we get through the webinar. Today's program is the welcome and introduction. The second part is understanding erectile dysfunction, key concepts, impact and assessment, and that will be hosted by Dr. Gerald Brock. Our third section will be pharmacological management of erectile dysfunction, the current evidence and best practices, which will be led by Pablo Caballero Portero. Our fourth section will be erectile dysfunction management, a review of non-pharmacological approaches, and that will be hosted by Brad Butt from Australia. We will then move to managing erectile dysfunction in the pharmacy, a person-centered approach. And I thank Regina Ahmed, Guidance Manager at the Royal Pharmaceutical Society in the UK, for presenting that section. We will then have a section entitled Erectile Dysfunction, a handbook for pharmacists on managing symptoms and supporting self-care, by Dr. Ines Nunes de Cunha, FIP Practice Development and Transformation Manager, based with FIP in the Netherlands. We will then move to the questions and answers, and then we will have a wrap-up and conclusion. The learning objectives today are to understand the definition, classification and burden of erectile dysfunction, including its impact on quality of life. We want to be able to recognize key risk factors, pathophysiology and assessment methods to support individuals with erectile dysfunction. We want to explore evidence-based pharmacological and non-pharmacological treatment options for the management of erectile dysfunction. We want to be able to identify the role of the pharmacist in the management of erectile dysfunction, including over-the-counter supply considerations and patient-centered care. We want to become familiar with the new FIP publication on erectile dysfunction and how it can support pharmacists in managing symptoms, promotions, and self-care. By way of background, I would just like to spend a brief minute explaining to people the bedrock, the foundation of what we're talking about today. A lot of it is based on the vision of community pharmacy practice from the community pharmacy section within FIP. As we look around the world, we can see that there are 4 common pillars to the everyday practice of a community pharmacist. And that is notwithstanding that there will be practice settings outside of community pharmacy, which is relevant to erectile dysfunction. But I think what we might do today is just suggest that this is an area of practice that pharmacists can excel at and where pharmacists are needed to work. Of the 4 pillars, we can see that pharmacists review medicines, pharmacists administer medicines, pharmacists dispense medicines, and pharmacists prescribe medicines. We can see that there is a vital role for pharmacists and their unique skill set in erectile dysfunction. And the reason we know that is that all healthcare research points us to the fact that there is an underutilized skill set in pharmacy, that the demographics of the populations that we serve, but also the professions we work in and we work with, are changing. We know that there are proven improved outcomes when pharmacists are more involved in people's care. And we also know that people want us as pharmacists, particularly in the community, to do more for them. We have spoken a little today about self-care, and it will be something that runs through the theme of what we talk about today with erectile dysfunction. With that, I think it's probably no harm to refer back to our own publications within FIP about self-care. But briefly to say that self-care is a model where people are central and empowered, and professionals should assist rather than paternalistically assume care. It reflects the breadth of self-care from day-to-day decisions and lifestyle choices, disease prevention and management of short and long-term conditions. The other end of the continuum of care represents areas where professionals have a greater responsibility, recognizing that self-care has a role at all times, with rare exceptions. Self-care is not a new concept, but it does not always fit with the biomedical approach to medicine. However, it is fundamental to good health, well-being, and sustainability of health services. The holistic approach that underpins is recognized by all healthcare professionals. So, ladies and gentlemen, with that introduction, And with the knowledge that we have an expert panel here to talk to us about a very important subject, I would like to introduce to you Dr. Gerald Brock. Dr. Brock is a urologist and basic researcher who has published more than 275 peer-reviewed scientific papers and received more than 20 national and international awards for work in male sexual health. Dr. Brock is the past president of the International Society for Sexual Medicine and is past president of the Canadian Urological Association. Ladies and gentlemen, it's my pleasure to hand you over to Dr. Gerald Brock. Thank you, Gerald.
Daragh, thank you very much. And I want to congratulate everybody that's been involved in creation of the handbook. I've had a chance to review it, and I think it's an amazing resource, and I hope your members will use it, as well as pharmacists, perhaps, who aren't even members of your society. Next slide, please. I've been asked to look at erectile dysfunction, and I think to put it in perspective, is this something common? Is it something uncommon? And this was a survey that we did about 2 decades ago now. So it looked at 47 different countries around the world, from Asia to Europe to North America. And the question was, does a man's sexual function decline with age? And the answer was almost uniformly yes. It depended on the region. So Hong Kong, 91% thought it did. And then we asked what age, and you could see typically between 50 and high 60s was the answer, that man's sexual function declines. New slide, please. We also asked them, how important is sex in your overall life? And I think this goes to the heart of the reason why the presentation is happening today. For the vast majority of regions of the world, whether it's the third world, whether it's the Western world, across all cultures, sex is a very important part of overall life. New slide, please. So when people are suffering, and couples are suffering from sexual dysfunction, they're looking for something very simple. They want to be cured. That was what this study showed. Well, the truth is, even today in 2025, we do not have a cure for erectile dysfunction. We don't have a cure for hypertension. We don't have a cure for diabetes or for dyslipidemia. So that's not a surprise. But for most patients, they want it cured, and that's not possible. They want something that's pleasurable. They want a partner satisfaction. And if you look down this list, you can see spontaneity and control and naturalness. And so keeping that in mind, new slide, please, we can see that really what we're looking for is something that will fit in with most of those objectives. If we go back now more than 30 years, it was 1992, new slide, please. And back then, this was a cool car. So things have changed quite a bit. New slide, please. Back in 1992, Michael Jackson was really the guy in popular music. New slide, please. And what was happening around the world was men were dying in droves, particularly in the Western world. New slide, please. And we can see that if we look at the incidence, new slide, of men who were in ICUs, it was in the US alone at that time, it was roughly 600,000 men were dying of cardiac disease. It was prevalent, it was important, it was impactful. New slide, please. And it was around that time that studies started looking at really what was happening. And inflammation was found to be a cause. New slide, please. And the idea that we could then look at a drug, an oral drug, that would increase coronary blood flow was really exciting. And that's really the birth of the PDE5 inhibitors. And of course, all of us probably on this webinar understand that it was that science and that research program that really found, surprisingly, that men with cardiac disease taking a PDE5 inhibitor had an improvement in their erectile function. New slide, please. It was also around that time that the Massachusetts male aging study was done. And it was very clear that if you were somewhere over age 40, you had more than a 1 out of 2 chance that you had some degree of erectile dysfunction. Now, for many men, it was minor or moderate or minimal, but for a significant number, it really impacted on their quality of life. New slide, please. We also found back then that it was age dependent, so that if you were in your 3rd decade of life or your 4th or your 5th, there was a progressive increase in the likelihood that you would have sexual dysfunction based on inability to get and keep an erection. So it was incredibly powerful that we could know and predict that a man would have erectile dysfunction. But what were those elements that really led to that 34% of men in their 60s, or more than 50% of men in their 70s, having erectile dysfunction? New slide, please. Well, there's a couple of causes, of course, of erectile dysfunction. It could be organic, and by that what we mean is it could be vascular or a problem with nerve signaling, or hormonal like low testosterone or high estrogen, or is it structural and organ injury or medication? There was a study by Slag in about 30 years ago that said almost 1 in 4 men have medication-induced erectile dysfunction. New slide, please. But it also could be psychogenic. It's anxiety provoking. Is it situational? Is it just concern that you have a high adrenergic tone? You're stressed out, and so your sympathetic nervous system is really pushing the adrenaline, and as a result, you don't get the vasodilatation you need. But now, new slide, it's clear that in fact, probably it's a combination, that it's both organic and situational, and most clinicians would look at erectile dysfunction and sexual dysfunction in most patients and couples being a combined effect. New slide, please. And if we look at probably the most critical thing is that most people who have erectile dysfunction will never ask a doctor, but they may very well present to a pharmacy. And really, that's the whole thrust of my presentation, that as pharmacists, you are so well positioned to offer these individuals help and care and knowledge, and that's where the handbook really is absolutely critical. New slide, please. So these are the 4 big causes of erectile dysfunction. New slide, please. You know, you can see here as shown as a bit of a joke, but these 4 overweight guys with obesity, hypertension, high cholesterol, and diabetes, these would be the poster children for getting and having problems with erectile capacity. New slide. So just to give you a little bit of physiology, the penile circulation is unique in our body. Compared to your coronary arteries or other vascular beds, the penile vascular bed has to dilate more than any other part of your vascular system. From rest, where you may have 1 or 2 cc's of blood per minute going into the penis, to be able to get an erection, the blood has to rush into the penis, and probably a 100-fold increase in vascular capacity. The coronaries may increase 5-fold, but the penile circulation has to increase 100-fold in order for the penis to fill with blood, pressurize, and seal off the outflow channels. New slide, please. So when we think of a penile erection, we think of what's happening normally. Well, normally the muscle in the penis and the vessels in the penis are contracted. They're in a static, tonic, contracted state. And these are the neurotransmitters that affect that. New slide, please. But to get an erection, you need to have the penile muscles relax. And that's where nitric oxide and smooth muscle mediators that result in high levels of cyclic GMP really affect smooth muscle relaxation. New slide. Back in the 80s, of course, we only had intracavernosal injections, which were really not very palatable for a lot of patients. New slide. But fortunately, as things developed, and new slide, please, this was really the important new discovery back from New England Journal of Medicine in 1998, where sildenafil was shown in a couple of studies, new slide please, that it had incredible dose-response relationship to really improve erectile capacity. And the slide is hard for you to see, but really what it says is at 25 milligrams, there was some effect. At 50 milligrams, there was more of an effect. But at 100 milligrams, almost all the patients had a really significant improvement. And that's an important message. You should always tell your patients to start their PDE5 inhibitors at the highest dose. Although they may have some side effects, you can deal with side effects. But the idea of giving a pill to somebody and them not responding, it can be devastating to men and their partners. New slide, please. And this just shows in a graphic form that really it affected a whole bunch of things in terms of erectile function, orgasmic function. But interestingly, it did not increase sexual desire. And that was important because we didn't want to have a pill that would cause these men perhaps to have so much desire that there may be a concern about sexual aggressiveness or other issues. So the PDE5 inhibitors work, but they require sexual stimulation release of nitric oxide, increased levels of cyclic GMP that cause the muscle to relax, and the drugs inhibit the metabolism of cyclic GMP. That's the whole goal of PDE5 inhibitors. New slide, please. So I just wanted to go through this quickly, that PDE5 inhibitors, which really are the main thrust of erectile function treatment today, and you're going to hear more soon, work regardless of etiology, severity, duration. New slide. They work regardless of race and ethnicity, the age. It works in younger patients, older patients. It works if you're thinner or you're heavier with your BMI. New slide, please. And it also works across all these various etiology, whether it's a diabetic cause where you have both neural and vascular problems, whether it's with ischemic heart disease, peripheral vascular disease, after surgery where the nerves to the cavernosal smooth muscles are cut, the cavernous nerves. It works in hypertension, depression, with antidepressants, and even with antihypertensives. New slide. And that's true, of course, for all PDE5 inhibitors. New slide, please. It works for vardenafil, tadalafil, sildenafil. I wanted to just spend a minute talking about the different pharmacokinetics. And of course, I think all of the people listening to this program understand that sildenafil has a relatively short half-life, whereas tadalafil, with a half-life of 17 hours, provides a different pharmacokinetic effect. New slide, please. And because it does have a long half-life, the idea of treating men with a very small dose on a daily basis allows for accumulation by day 5 or day 6, such that you get basically a steady state within the therapeutic range, which for many of the patients is a huge advantage. And I think it's an underutilized approach that we as clinicians and pharmacists should really make ourselves available. New slide, please. So this just shows the data that with tadalafil, daily dose compared to on-demand across a variety of different conditions really is very effective. New slide. Lets that man be quite spontaneous. And the question is, what is the future for PDE5 inhibitors hold? New slide, please. Well, it's really exciting. New slide, please. Because PDE5 inhibitors, of course, target vascular pathology. So they are, of course, approved for pulmonary hypertension. They have an effect, although it's modest, on overall systemic hypertension. We know, of course, they work really well for erectile dysfunction. And now in many parts of the world, they're also approved for lower urinary tract symptoms. Recently, within the past year, there's been a wonderful study by Cloner out of California that shows they in fact have an effect on endothelial function and are cardioprotective. New slide. So just to reiterate, there's lots of testing you can do to really define the etiology from a pharmacist's point of view. I wanted to just make the point that yes, there are tests there, but they are really almost never used and really not very important. New slide, please. That we can look at actually the overall algorithm, where really I think this is the most important slide that tells you that you can look at the patient, their partner, identify risk factors, assess their psychosocial situation. The physical exam really does not add very much. And I know that as pharmacists, you probably will not do physical exams, but I can tell you that they add very little unless the gentleman says he has a penile deformity, he has a curvature consistent with Peyronie's disease. The laboratory tests are typically quite modest, including testosterone. You know their medical history because you're their pharmacist, and as a result, prescribing and giving them advice about erectile function is really critical, and I think the pharmacist is absolutely perfectly positioned to do this. So I wanted to thank the organization for allowing me to do this presentation, and I look forward to your questions. Thank you very much.
That was an absolutely fantastic presentation, Gerald. I don't know if you can see it, but there's lots of thumbs up and hearts coming up on my screen, which is very good feedback. We already have one question which has gone into the Q&A, but what we'll do is we'll leave the questions, if it's okay with you, Gerald, for the general question section that's there. That's fantastic. And also to congratulate you on some really nice graphics that were there that people are going to appreciate when they can log back in and get into the granular detail of what you got there. So that was fantastic. Gerald, thanks again.
My pleasure.
Colleagues, ladies and gentlemen, it is now my pleasure to introduce the next section titled Pharmacological Management of Erectile Dysfunction, Current Evidence and Best Practices. And this will be presented by Pablo Caballero Portero, and he has his degree in pharmacy from 2020 from the University of Murcia in Spain, and has worked as a community pharmacist from 2020 to 2022. But since September 2022, he works as a pharmacist with the General Pharmaceutical Council of Spain in scientific dissemination. So, Pablo, it's my great pleasure to hand over the next section of our webinar to you.
Thank you, Daragh. It's a pleasure for me to be with you on behalf of the General Pharmaceutical Council of Spain to discuss the pharmacological treatment of erectile dysfunction, or ED, a topic of significant current relevance, and I want to thank the Federation for this opportunity. Over the next minutes, we'll review the spectrum of medical treatments available, how to tailor them to individual patient needs, safety considerations, strategies for patients who fail initial therapy, and the pivotal role pharmacists play in optimizing outcomes. Let me start by giving you a quick overview of what we'll be covering today. First, I'll set the scene with a general overview of erectile dysfunction and its pharmacological treatment. Then we'll dive into the main class of drugs, phosphodiesterase type 5 inhibitors. After that, I'll talk about other therapeutic options, starting with intracavernosal injections, followed by topical and intraurethral alternatives. We'll also briefly touch on hormonal replacement therapy and see how some of these approaches can be combined for better outcomes. Next slide, please. Erectile dysfunction can stem from vascular, neurogenic, hormonal, anatomical, or psychological causes. Fortunately, our toolbox for pharmacological intervention has experienced a significant expansion. Broadly, we can classify treatments into oral agents, mainly phosphodiesterase type 5 inhibitors, or PDE5 inhibitors, such as sildenafil, tadalafil, vardenafil, or vanafil. Local therapies, mainly with alprostadil via intracavernosal injection, intraurethral stick, or topical cream. Mechanical options like vacuum erection devices, and surgical intervention with penile prosthesis. A stepped approach allows us to match a patient's clinical profile and personal preferences with appropriate balance of efficacy, convenience, invasiveness, and risk. Lifestyle modification and risk factor control are foundational. Encouraging smoking cessation, regular exercise, weight loss, and glycemic or lipid control not only benefit cardiovascular health, but can also improve erectile function. Besides this, first-line treatment interventions include the use of PDE5 inhibitors. Second-line treatment options mainly consist of intracavernosal injection therapy, intraurethral alprostadil, or alprostadil cream. And for patients who do not respond to or decline those options, a penile prosthesis offers a high satisfaction rate. There are two main types, malleable and inflatable, that provide mechanical rigidity on demand. However, this is invasive and irreversible, so it remains a last resort. The main goal of pharmacological treatment for erectile dysfunction is to improve patients' quality of life by restoring satisfactory sexual function. Beyond addressing the physical symptoms, treatment aims to reduce psychological distress, promoting overall well-being and confidence. Next slide, please. As mentioned earlier, when lifestyle measures are insufficient, PDE5 inhibitors become the cornerstone. Let's briefly review their mechanism. PDE5 is an enzyme in the corpus cavernosum that degrades cyclic guanosine monophosphate, or GMP, and the inhibition of PDE5 prolongs cyclic GMP activity in response to nitric oxide released during sexual stimulation. The result is a smooth muscle relaxation, arterial inflow, and erection in the presence of sexual stimulus. We have 4 agents approved in Europe. Sildenafil or vardenafil typically start working in about 30 to 60 minutes and last for around 4 to 12 hours. Tadalafil has a similar onset, but a much longer duration of up to 36 hours, which is why it's sometimes used as a daily treatment. And the vanafil has the fastest onset, around 15 to 30 minutes, and its action lasts about 6 hours. They demonstrate comparable efficacy and safety profiles at equipotent doses, so the choice depends on factors such as the desired window for spontaneity, cost, or the frequency of intercourse. For example, the tadalafil is safe, well-tolerated, and effective, making it a good option for sexually active couples who prefer frequent and planned sex rather than adhering to a dosing schedule. But specialists should review this treatment regularly. While generally well-tolerated, PDE5 inhibitors require careful consideration regarding patient safety. Pharmacists dispensing these medications should be aware of potential common side effects like headache, dizziness, flushing, nasal congestion, muscle pain, or visual changes, including color distortion, but mainly blue vision or cyanopsia. Regarding contraindications and interactions, the concomitant use of PDE5 inhibitors with any organic nitrates, including nitroglycerin or recreational poppers, is contraindicated due to the risk of severe and unpredictable drops in blood pressure. Alcohol consumption presents a double challenge. It's a risk factor for ED and also interferes with the treatment by impairing erectile function and by lowering blood pressure. For patients not responding well to PDE5 inhibitors, pharmacists should first assess if the medication is being used correctly, including proper dosage and allowing sufficient attempts, at least 6, and if ineffective, hypogonadism should be investigated as possible underlying factor. Combining tadalafil with a shorter-acting inhibitor might be considered for severe ED, but requires caution and close monitoring due to limited robust evidence. The increasing trend of self-medication and misuse of PDE5 inhibitors is concerning. Obtaining these drugs without prescription can lead to incorrect usage, and there is a risk of counterfeit products with unknown quality and safety. Pharmacists play a crucial role in educating patients about the proper use of these medicines, identifying potential misuse, and emphasizing the necessity of medical consultation. Next slide, please. If a patient fails or cannot tolerate PDE5 inhibitors despite proper use, we can move to second-line options. Particularly for those who don't respond well to oral medications, we have intracavernosal injections. This approach involves directly injecting medication into the corpus cavernosum of the penis to induce an erection. Alprostadil, a prostaglandin E1 analog, is the most common drug used for this purpose. The procedure itself is a key aspect to discuss with patients, ensuring they understand how to safely and effectively administer the injection. The dose used is 5 to 40 micrograms, and erection occurs in 5 to 15 minutes, with duration being dose-dependent and offering a good efficacy of about 70%. Its main risk is prolonged priapism, and any erection lasting longer than 4 hours mandates urgent medical attention. Beyond alprostadil alone, there are alternative options and combinations used. Historically, papaverine, a vasodilator, and phentolamine, an alpha-adrenergic blocker, have been used individually. Sometimes these are combined to enhance efficacy and potentially reduce side effects in patients that haven't responded to single agents. More complex combinations also exist, such as a combination of papaverine, phentolamine, and alprostadil, often referred to as trimix. This aims to leverage the different mechanisms of each drug. Next slide, please. Another option we can discuss is topical alprostadil. This comes as a cream to be applied to the opening of the urethra, and it's designed for a quick absorption into the penis, usually working within 5 to 30 minutes, with doses around 200 to 300 micrograms. Some men might experience temporary redness, burning, or mild pain. It's not suitable for everyone, particularly those with certain penile conditions, like abnormal penile anatomy, or with risk factors for prolonged erections or blood clotting issues. There's also intraurethral alprostadil that involves inserting a small applicator into the urethra after urination. While it's less invasive than injections, it tends to be less effective, with an effectiveness of around 30 to 60%. The dose can range from 125 micrograms to 1 milligram. And a key step here is to gently massage the penis for a short while after application to help the medication coat the urethra properly. While systemic side effects like headache or dizziness are uncommon, they can still occur. Similar to the cream, It's not recommended for men with abnormal penile anatomy or a predisposition to priapism. When selecting a second-line therapy, patient dexterity, willingness to self-inject, pain tolerance, and convenience are factors to be considered. Next slide, please. Now moving on to hormonal replacement therapy. This is considered when there's confirmed testosterone deficiency and only after evaluation by an endocrinologist. Testosterone can be given orally, transdermally, or by intramuscular injection, but only if other causes of testicular failure have been ruled out. It's not suitable for everyone. Contraindications include history of prostate cancer, severe benign prostate hyperplasia symptoms, or recent stroke. Once therapy begins, checkups are recommended every 3 months during the first year with those adjustments as needed. Next slide, please. Now let's briefly look at combination therapy. This is sometimes considered for patients who don't respond well to monotherapy. And the most common combinations include a PDE5 inhibitor with either an intracavernosal injection like alporstadil or with testosterone replacement. While these combinations may improve outcomes, they also come with a higher risk of side effects, especially priapism. It's important to note that these are off-label uses, so they should be prescribed with caution and only after exhaustive patient evaluation. Next slide, please. So finally, to summarize, the treatment of erectile dysfunction offers a wide range of pharmacological options, from oral PDE5 inhibitors to intracavernosal and intraurethral agents, allowing for personalized choices based on each patient's needs and preferences. A stepwise, individualized approach is key. We usually begin with lifestyle changes, PDE5 inhibitors, or even a vacuum device. If those don't work, second-line treatments include alporstadil, either as injections, cream, or intraurethral inserts, and as a last resort, there's penile prostheses. PDE5 inhibitors remain the cornerstone of therapy, with 4 available options that are generally similar in efficacy and safety, and the choice depends on factors like how often the medication is used, how long it lasts, or its cost. Safety is also essential. We should watch for issues like low blood pressure, visual changes, or priapism. Those adjustments may be needed with liver or kidney problems, or if other medication affect metabolism. In non-responders to PDE5 inhibitors, it's important to confirm the medication has been tried properly at least 6 times and rule out hypogonadism. If needed, adding testosterone or switching to another alternative can be considered. And finally, pharmacists play a crucial role by guiding patients on proper use, identifying misuse or counterfeit products, and referring patients to a doctor when needed. Thank you for your attention, and I welcome any questions.
Pablo, what a fantastic presentation to give us the pharmacological background to helping, starting with self-care all the way through to all the pharmaceutical interventions that are available, which backs up nicely what Jared was talking about through the pathophysiology of erectile dysfunction. What was an interesting one, we had a great question come through on the Q&A, which you referenced. So just to let everybody know, we're delighted to get the questions, but it'll make more sense to take all the questions together. So Pablo will have an opportunity later to answer one specific question that I saw coming in referencing Papaverin. Anyway, let's move on. And thank you, Pablo. And again, I can see lots of fantastic emojis coming up through my screen, thanking you for your presentation. Our next presentation from the other side of the world is a colleague of mine who I share a particular interest with since I was good enough. It was a really exciting thing for me to do when we were at the World Congress in Brisbane. I went and visited a colleague of Brad's to see how Men's Health Down Under works in operation to getting really good care to men who need it through their community pharmacies. So please let me introduce Brad Butt. Brad is going to talk to us about erectile dysfunction management, a review of the non-pharmacological approaches. Brad is a pharmacist and founder of Men's Health Down Under, a pharmacist-led men's health clinic with multiple sites across Australia. He is a pharmacist and passionate about the health and well-being of his local community in Canberra, where he practices, but also to the broader Australian male population. and with today, I suppose, the worldwide male population. So Brad, it's a pleasure to have you with us, and yours is the webinar.
Lovely. Thanks, Darren. Thanks for the invitation, folk at FIP. It's lovely to be able to join pharmacists and pharmaceutical colleagues from around the world. This is great. Next slide, if I might, please. I just thought it was worth noting, we're only going to have a quick chat today. So just to scratch the surface on a few of the following, a bit of information on the barriers to discussing and treating erectile dysfunction. As pharmacists, it can be tricky to bring these things up, and we acknowledge that. Some misconceptions around erectile dysfunction. We do know that some of the patients coming in might have preconceived ideas that might not necessarily be correct, and we can certainly help them with those questions as pharmacists. Lifestyle modifications, and I know Pablo touched on some of this. These are really important, and these absolutely fall under the scope of what a pharmacist can do. And a bit of information on the medical devices for erectile dysfunction management. And there's perhaps more than you might think. And we can see our friend Austin Powers there, who really probably, brought the penis pump back in some respects. They were quite popular in the 70s, perhaps, for more cosmetic reasons, and became a bit more topical again with Austin and his penis pump. We use a lot of penis pumps, and I'll give you a bit of information about that as well, because they do form a valuable part of the treatment regime. Also, we'll touch on implantable devices versus external devices. And again, Pablo touched on that, so we'll have a quick look at that as well. Next slide, please. All right, so barriers to discussing and treating erectile dysfunction. Look, I think probably the critical bit here is that the barrier really is discussion. The treatment, as we've already heard tonight, is actually relatively easy, particularly from a pharmaceutical perspective. It maybe a bit of counselling might be required, but the treatment bit's not so hard. So if we think about discussion as the barrier, we know that it's tricky to find the time with patients, particularly in a busy community pharmacy practice or in a clinical setting. Sometimes time is against us. Certainly in our clinics here in Australia, we actually allocate upward of an hour to sit down with the guys and talk to them. We know that by allocating the time to have a general conversation about their health, we can actually get into the nitty-gritty. And often one of the things we try and touch on is erectile dysfunction, particularly for those that have got prostate issues, blood pressure or cardiovascular issues, diabetic issues. And we know that if we've got time, we can actually open these conversations up, and not just that, but do them justice. Often there's that embarrassment issue or the taboo nature of sex. I mean, we've all got, half the population's got a penis, the other half's got a vagina. It's quite okay to talk about these things, and as part of a relationship, to have intercourse and to be intimate. So it's important to talk about them. Breaking down that embarrassment can be tricky. Although interestingly, I think once you've got a bit of a conversation going, the guys are very happy to actually open up about it and tell you more. I do think it's interesting. One of the strategies I find quite good is to let the guy know that they're not alone. And we've probably all heard that before. And this is just in Australia, there's 1 million men at any one point in time suffering from erectile dysfunction. So it's relatively common, and it's no different to having, mental health trouble or blood pressure. It's something that we can manage, and we've got to do a good job of it to get a good outcome. Practitioner training and confidence. Look, this ties into having those difficult conversations or conversations which might feel uncomfortable. But if we've got good training and a confidence about what we're talking about, as with anything that you're an expert in or a bit of an expert in, that gives you the confidence to have these conversations with patients. So when we listen to Dr. Brock and to Pablo tonight, it's this sort of level of information that you can garner, take on board, and try and relay to a patient in a simple way. If you've got that baseline knowledge, it's amazing how much easier it is to talk with a degree of confidence. I think sometimes patients also think that erectile dysfunction is a natural part of aging and that it's irreversible and there's nothing that can be done about it. Look, some of that is obviously true. Erectile dysfunction will decline, as we saw in Dr. Brock's presentation. It will decline with age, but certainly it's not irreversible. And we know that there's plenty that can be done. There's many options. Pablo talked about first line, second line, third line options. And within each of those treatment lines, there's a multitude of different things we can do. And we can, in fact, we can use a couple of options from each of those different ones. I mean, with the exception of implantable devices, they are permanent, but we can use a penis pump with tadalafil, or we can combine different ones to get a bloke a good outcome. So I think that it doesn't have to be irreversible. It may require management of, you know, some anxiety or some blood pressure, cholesterol, diabetes, but it doesn't have to be irreversible. And in fact, managing the general health can actually improve the erectile health. We do know that erectile dysfunction is referred to as the canary in the coal mine, in that it might be the first indication that something else is awry and be a referral point for us as pharmacists, seeing that in our clinics and pharmacies, to refer the patient back to their doctor to get some sort of diagnosis. Obviously, there's a cultural difference sometimes, language barriers and financial constraints, and these are real issues. I think sometimes we sort of gloss over them, but certainly the financial constraint can be tricky. So, you know, some patients might actually, and I'm coming at this with a bias because I'm talking about non-pharmacological treatments to manage erectile dysfunctions. Sometimes the purchase of a vacuum erection device or a penis pump, it's a one-off expense, and that actually might be beneficial for the patient. They buy it once, they've got it, they can use it as often as they like, and don't have to spend, you know, a whole heap of additional money on injectables, which can be relatively expensive and often not subsidised, tablets, which certainly in Australia are not subsidised by our government for patients as well. And of course, one of the other barriers we see is possible side effects, drug interactions, and comorbidities. And as pharmacists, we can be pretty risk adverse sometimes, I think, and our GP colleagues and friends can be as well. But at the very fundamental level, the medications are relatively safe. The question is more about how safe is it for that patient to have intercourse and get their heart rate up. That strain can cause some trouble. Obviously, if they're on nitrates, that can be a problem, but it's actually about the person's level of fitness and how safe it is for intercourse. Next slide, if I could, please. Thank you. Misconceptions. Many of us have come across mythbusters, so it seemed appropriate to talk about them almost as these misconceptions as things that we can bust. ED is an inevitable part of aging. No, it's not necessarily. I think with good physical health, good mental health, you know, it doesn't necessarily have to be. Yes, we might find a decline in erectile function as we age, but there's certainly things we can do to make that erectile function nice and healthy and prolong it into older age. We see about 1,000 patients a year in my Canberra clinic, and it's amazing how many of these guys who have had prostate cancer surgery that might be in their 50s, 60s and 70s had fantastic erectile function up until their surgery. So absolutely, it's not necessarily a part of inevitable aging. It's a permanent condition. Not necessarily. We can absolutely do things to improve our general health and fitness and wellness, which can improve erectile function. I think it's important to reiterate that to men because it can be quite depressing for them. You know, they have a bad experience with medication or without medication. That can impact on their mental health, and it's quite cyclical. So they quickly end up in this position where they think, this is never going to get better. I can't understand what's going on. So we need to reiterate to them, it doesn't have to be permanent. There's plenty that can be done. And we might need to tweak a few things and we need them to put input in. But if we've got their permission to help them and put them in touch with the right people, we can actually help to improve that and make sure it's not permanent. ED is just a man's problem. We get this a little bit. It's absolutely not just a man's problem. It might start as a man's problem, but it becomes, you know, part of a relationship problem possibly, and it can affect the way that male has a relationship with their partner. So that is absolutely critical to consider. You know, it takes two to tango. So we need to make sure that the man knows that this is important, not just for him, but for the health of his relationship with his partner as well. ED only affects sexual function. We know that that's not correct. Yes, it affects sexual function, but it could actually be an indication that something else is going on and needs to be addressed. It's purely psychological. No, well, there's often an anatomical or blood flow issue that's involved. Dietary supplements and herbals are safe and effective. Look, again, as pharmacists, this is not a surprise. We hear it often. but we know that it's not always the case. There can be interactions. The stuff can be quackery. We see patients spending a lot of money on some of these things, and they can be relatively ineffective and delay appropriate medical treatment by their physician to figure out what's going on. So these are really a bit of a bane of our existence, unfortunately. Medication is the only solution. And again, with the bias of my presentation tonight, absolutely medication is not the only solution. We've got some terrific medical devices that can be used, which you know, are great, and we'll get to them in a tick. Next slide, please. Lifestyle modification, and look, I'm not going to harp on here. This is a lovely slide, and it's part of the publication that FIP have put together, so I'd encourage you all to get in there and have a look at it. And it details to us things that we can do to help a patient or talk to them about that doesn't cost them anything necessarily, that's going to not only improve their erectile function and general health and well-being, it's going to be good for them in the longer run as well. Things like sleep management, you know, making sure they get adequate sleep and healthy sleep, good REM sleep, sleep apnea, all these sorts of things. Exercise, we know that physical activity is really important to improve blood flow, reduce cholesterol, improve cardiovascular health, keeping their body weight within a healthy range. And, you know, with all the injectables that are coming out, we're seeing more and more people that are focusing on weight management. And that's a fabulous thing from a cardiovascular health and general health and well-being perspective, but also for their erectile function and self-worth. I think it's really critical that we consider these things. Dietary changes ties back into weight management. But equally, you are what you eat, so you've got to have a good, healthy diet. We've got dietitian friends that we can get assistance on that stuff from. Smoking cessation, we know that smoking's no good for us. We know that it affects circulation and cardiovascular health, so let's look at that and make sure we've got that as good as we can. And alcohol moderation, you know, the world seems to consume a lot of alcohol. We know that that's not great for erectile function. So these sorts of things, these are our first principles. And if we can get this stuff right, perhaps we can get away with not having to do too much intervention to help the guy with his erectile function. Next slide, please. Medical devices for erectile dysfunction. And look, these, I think, these form a large part of what we do here in Australia. Obviously, we do a lot of assistance for the patients with, you know, injectable therapies and intraurethral gels and tablets for erectile dysfunction. But often I think we as pharmacists, and I think even the medical fraternity, forget about the importance of medical devices. So, you know, the penis pump, for example, was first considered, well, it was probably before the 1900s, I suspect. But by and large, you know, 1900s, they were thinking we could probably use a pump to help engorge the penis. And that could be a bit of an aid for guys that had erectile dysfunction. Restriction rings, you know, they're an obvious part that we need. We can draw the blood into the penis with a vacuum erection device or a penis pump, but we need something to keep it in there. Restriction rings are interesting. I don't know how many people have used them. If you haven't and you're a male, I'd encourage you to have a look at a restriction ring with or without a penis pump. They can be tricky to use, and when you put them on the base of the penis, they can cause a hinging effect, because what happens is they squash the cavernosal tissue to trap the blood in the forward part of the penis, and in doing so, that means the cavernosal tissue behind the ring, which goes right down near the perineum, it ends up without blood in it and squeezed tight where the ring is, and you can get a hinging effect, which can make penetration quite tricky. You know, in using a restriction ring, the penis can feel a little cooler to the touch. The blood vessels would jump out more. So I suppose what I'm saying is that the erection you get with an erection pump, a vacuum erection pump, and a restriction ring, it's a little different. And I think it's important that we reiterate that to patients so they don't get a surprise. We do know that patient satisfaction with pumps is pretty good, but the key here is that we need to talk to the patient about the expectations. When we talk to the patient about the expectations about what a penis pump can do for them, how to use it, what to expect, how long to leave a ring on, and we give them the information they need, they're far more likely to be satisfied with it. If we simply provide them with a pump, in the same way, if we provide them with a cholesterol tablet or a blood pressure tablet and don't give them the information, they don't get the same benefit from it. So I think we need to couple advice and device, and that's really critical. Traction devices, These things are really interesting. There's been some really nice studies done on traction devices, mainly in the treatment of Peyronie's disease, which is where the penis can experience some curvature because of some plaque or scar formation within the cavernosal tissue. But we also know that traction devices not only stretch the penis and make it larger and longer and straighter, but they do increase erectile function. So these are things like, I'm not sure if I can use brands, but for your own purposes, so you can have a look. There's not many of them. There's an Andro-Peyronie device, there's a Penny Master, and there's the Restorex. So they're 3 examples of penile traction devices, which I think are absolutely worth a look. And you know, they may not be the most comfortable things to wear, but they give patients another option to try. And I think if you look at the next option, the fourth point there, these implantable devices, they are irreversible. Once they go in, they don't come out. Patient satisfaction rates with them are really high, but a lot of guys are nervous about going in for surgery under the knife to have something done. So we can make them and help them and their surgeons and their physicians around them feel more comfortable that they're doing the right thing by ensuring that they've at least been made aware of these devices before they get to doing an implantable device. So the implantable devices, and I know that Pablo touched on it before, are the ones you can see on the screen. There's a couple of different ones. They're made by a few different companies globally, but really they're all very similar. There's an inflatable device and a rigid device, and I think I've got a slide coming along which will talk a little bit more about them. Next slide, if I may. Medical pumps. I just think it was worth touching on non-medical and medical. Medical grade vacuum pumps are actually CE approved, TGA approved, FDA approved. They're Rigididge. They're the real McCoy. They're the one that we should be recommending to our patients. They're going to do the right job. They're not going to cause patient harm when they over pump and implode on their penis, as opposed to the toy you buy at the sex shop. I would encourage anybody who's talking to the patients about vacuum erection devices to make sure you're using something medical and not a non-medical device. Look, in terms of when you might use it, definitely for erectile dysfunction, and we use them a lot after for the guys who have had prostatectomies done. As a rehab tool, the guy would use it on a daily basis, and they can use it for intercourse as well with the ring. Benefits being that it's a one-time cost. They're very effective. They'll absolutely help the bloke get an erection to the point which is adequate for penetrative sex. It will feel different, but it would be adequate with some lubricant. Drawbacks being not many. They tend not to have many side effects. You can get a little bit of spotting patachi on the surface of the penis where the blood vessels can break from being overpumped. And if you put a ring on which is too tight, they're pretty uncomfortable. But beyond that, and the way that they make the penis feel a little different, they are a really nice option for a patient to be given that's non-pharmaceutical. And I think that that's a nice choice. Next slide, if I might, please. Penis rings or restriction rings, there's so many different ones. They all do the same job. Some blokes like one that's thinner, some thicker. Some blokes like one that's got less tensile strength. Some like them more stretchy. Some go behind the scrotum. Some go in front of the scrotum at the base of the penis. And in fact, some of them, like the Firmtech ring, actually goes both behind and in front of the scrotum, which has a different effect again. They all work on the same principle and they will all do the same job, and they are relatively expensive, inexpensive, I beg your pardon. So they're a nice cheap option for a patient and they'll do a reasonable job. Next slide, if I might, please. Traction devices, this is an example of one, the Penny Master. As I said before, they will help with penile shortening, straightening of the penis, but they can also improve the blood flow to the penis. They would be worn for a fair period, and it's really important the patient gets the right advice on how to use them, because I think some of them can be complicated, and if you don't use them properly, it can actually cause some damage to the penis. So you have to make sure you know what you're talking about with these things. Next slide, please. The implantable devices, as we said before, gold standard, wonderful, a complete solution, not going to have to think about it again. They are done under operation by the urologist. The recovery can take some time. They are a permanent solution and they're quick and easy to use, which I think is really important. The inflatable one has a reservoir which lives in the lower part of the groin, and a pump which lives in the scrotum, which pushes the fluid from the reservoir into the cylinders within the shaft of the penis, making the penis appear erect. The rigid one goes in, it's malleable, so you can bend it and tuck it away, but essentially the penis remains in the erect state all the time, and it comes back to patient preference and cost as to which one they might like. They are a permanent solution, and once you've got it done, it's something that's not thought about again, which is really nice for a sufferer of erectile dysfunction, particularly if they've suffered for many years. I would also suggest, if you're talking to patients about it, if you know someone who's had one done, it can be really helpful for them to talk to someone who's had it done, just as to get a bit of extra information. Next slide, please. That's it. Thank you. Take questions at the end. Thanks for having us, and please get in touch if you've got any more information required on those slides this evening.
Brad, what a fantastic presentation. A great privilege for all the colleagues here today to listen to your insights, which are theoretical, but both theoretical and practical. I hope that people really appreciate the way that I'm appreciating how this webinar is moving. We've started with pathophysiology from Gerald, and Pablo was able to talk to us about pharmacology. And now with you and your practical experience, I think we're getting closer to the human being, because that's what we're talking about today, that this is going to be a person-centered approach. So leading on to that, and also to thank the contributors, because I can see some of the questions have been answered in real time in the Q&A. So thanks to Pablo and Gerald for answering those questions. So to bring us on to the next section, we have managing erectile dysfunction in the pharmacy, a person-centered approach. And this is going to be presented by our colleague, Regina Ahmed. Regina is a pharmacist prescriber from the United Kingdom. She works as the guidance manager at the Pharmaceutical Society, Royal Pharmaceutical Society, and her role is to write pharmacy guides, professional standards and frameworks to support pharmacists in their day-to-day practice across Great Britain. She has gained experience working in a range of pharmacy settings, such as general practice, community pharmacy, and other pharmacy organizations. Regina, it's my privilege to welcome you to your part of our webinar today, which is titled Managing Erectile Dysfunction in the Pharmacy, a Person-Centered Approach.
Thank you so much for the introduction and also the invitation as well today. So hello everyone, my name is Regina, and I'm really pleased to be here today to talk to you about managing erectile dysfunction in the pharmacy using a person-centered approach. Okay, next slide, please. So as a disclaimer, my talk is going to be quite generic, but it's mainly going to be focusing on practice in Great Britain, so England, Scotland, and Wales, because these are the countries that we represent at the RPS. In case you don't know who the RPS are, we're a membership organisation representing pharmacists and pharmaceutical scientists working across different sectors and settings, and we're involved in advocacy, learning, and professional development. So I would advise you contextualize this presentation to your own practice and apply any relevant legislation, regulation, and guidance in your area. And you should also contact the equivalent organizations where relevant. For example, the medicines regulator in your country regarding the class or supply of any medicine. Next slide, please. This is what I'm going to be covering today. So how pharmacists can help and the different ways that a person can access medicines for ED through a pharmacy, the counselling advice that you might want to give, and also implementation strategies that have been used in Great Britain as well. Next slide, please. And again, so the value of pharmacists. So how can we help? So number one, we are experts in medicines and minor health conditions. We provide convenient and timely access to healthcare services and ED treatments. We can improve the safe supply of ED treatments over the counter through patient assessments. We can identify risk factors through screening and diagnostic services. We also have the opportunity to start conversations as well. So people have quite a good rapport within their community with their local pharmacist. We can also promote self-care by supporting any lifestyle changes, review medicines, and people, most importantly, they're getting advice. They're getting evidence-based, reliable advice from a healthcare professional on the safe and effective use of their medicines. And also other members of the pharmacy team, or they also have relevant qualifications to help support, give health advice, for example, technicians and healthcare assistants. Next slide, please. So in Great Britain, all medicines are classified into 3 legal categories, which are prescription-only medicines, so POMs. So these must be sold or supplied according to a written prescription written by a healthcare practitioner. So that might be a doctor, dentist, a nurse, pharmacist, etc. You've also got pharmacy-only or P medicines. Now, these are sold or supplied at a registered pharmacy premises by or under the supervision of a pharmacist, so following a consultation. And then you've got general sales lists, which are GSL. Now, these can be sold from a wider premises, like supermarkets, but under certain conditions. So when it comes to erectile dysfunction medicines, they're mainly classed as prescription-only medicines, so POMs, or pharmacy-only medicine or non-prescription medicines. I'm going to be mainly focusing on accessing phosphodiesterase 5 PDE5 inhibitors through pharmacists in the community. So there are different ways. So you've got prescribing, dispensing, and over-the-counter. And I'll go through each one with you today. So next slide, please. So the first one is prescribing. Next slide, thank you. So I'm not going to go into too much detail, but I wanted to share this with you to help you understand the different ways a person can access ED medicines in the community. So in Great Britain, pharmacists, if trained, can prescribe medicines on prescriptions as long as it's within their scope of practice. And then from 2026, pharmacists will be graduating as prescribers from university. So for example, I'm a prescriber. I used to work in GP practice, so doctor's surgery. And in my case, it wasn't within my scope to initiate erectile dysfunction medicines, but I would continue treatments. So, for example, I might ask some of these questions within a review before re-signing that prescription and making sure it's suitable for them. If I worked in a community pharmacy, I would be able to set up something like a private prescribing clinic to support men's health, and that might include things like ED treatments as well. So here are some general considerations if you're prescribing ED medicines that are POMs, so prescription only. And this may differ where you are, and you should always apply your local practice. The first thing you do is take a thorough history. So that's your medical history, risk factors, social, lifestyle, relationship, symptoms, and any medication they're on. You then do an assessment as well. So make sure you're confident with that. So you might do physical examinations if needed, or investigations like blood tests. Then you would do your diagnosis, but it's really important that you know your red flags and also the differential diagnosis as well. And then for management, you'd want to follow local and national clinical prescribing guidelines and also identify evidence-based treatment options. You'd then present those options and reach a shared decision with your patient. So you wouldn't just say, this is for you. You'd ask them, what do they want? What do they prefer, etc. And then refer. You need to know who to refer to as well. So say, for example, you identify mental health issues within a conversation, you might want to also refer to mental health services as well. You also want to monitor and review to follow up on the effectiveness of the medicine. So you might do that a month later, etc. And then you want to give counselling advice. So informing the patient on how to take the medicine safely and correctly. And I'll go into more detail about that later. And also you might signpost to things like websites that might help them understand their condition a bit more. But most importantly, you'd want to document whenever you're prescribing every information that you're giving. Okay, next slide, please. So the next one is dispensing, and I'm sure you're all familiar with this. This is when you get a prescription for a PDE5 inhibitor that are prescription only from a prescriber, and that could be your doctor, your pharmacist, your nurse, whoever can prescribe. So in Great Britain, the process of dispensing includes a clinical check, a legal check, a label check. You provide counselling, and then you might even do a review to identify any kind of adherence issues. And then next slide. And next slide again. And then finally, you've got your supplying PDE5 inhibitors over the counter. So the supply of non-prescription PDE5 inhibitors through pharmacy is not authorized in all countries. And you should check with your country's medicines regulator on the licensing, sale, and supply of medicines in your area. But in Great Britain, you can access PDE5 inhibitors over the counter in 2 ways. So when I say over the counter, I mean going to your local pharmacy, having a consultation with the pharmacist, and they're able to supply a medicine. But there are 2 ways. You can do it through a patient group direction, which is a PGD, or a sale of a licensed medicine, usually a pharmacy-only medicine. Okay, next slide, please. So the first way is through a PGD. Now, PGDs are written instructions to help qualified healthcare professionals like pharmacists to supply or administer medicines like POMs, Ps, GSLs even, to certain people for specified clinical conditions under a certain criteria to make sure that it's clinically appropriate. So usually you don't go outside of that criteria, you wouldn't be able to supply it. These PGDs are written by multidisciplinary groups, including a doctor and a pharmacist and the healthcare professional that can use it. And the erectile dysfunction medicines that are usually supplied on a PGD in GB are PDE5 inhibitors, but the POM versions. There aren't many requirements to deliver that service. You might do some training if it's associated with the PGD, and you might submit a declaration confirming that you're competent to deliver that PGD and also sign those PGD documents as well. Okay, next slide, please. Then you've got the sale of licensed P medicines. So in Great Britain, sildenafil and tadalafil are licensed as pharmacy medicines, which means it can be sold to people over the counter from a pharmacy following a patient assessment by the pharmacist, usually using a questionnaire, and also if it's in line with its marketing authorization. For example, sildenafil and tadalafil, they're indicated for erectile dysfunction in adult men over the age of 18 years. This means that if anyone under the age of 18 years came and wanted to buy it, they wouldn't be able to. You would have to refer them to their clinician as appropriate. So each product will have conditions for their supply over the counter. So you should check with the individual manufacturer's product information. So as a pharmacist, you're going to need to ensure that the supply is safe and appropriate. So here are some general questions that you could consider asking people, and you can adapt these and apply to your practice where appropriate. But we recommend that pharmacists use the manufacturer's product information and their educational resources to support supply. They are really, really good sometimes. And the materials available are things like a pharmacist checklist and a pharmacist guide, which you might find useful. The other thing is also you might want to train your pharmacy support staff as well on how to handle these requests for OTC medicines and also know when to refer to the pharmacist as well. So the first step is identifying patient symptoms and concerns. So who's requesting the supply and what are the symptoms and concerns? So how old are they? Are you selling it within the licensed indication? If it's a representative, you also want to check, does the person give consent to that person asking questions on their behalf, and also for you to provide any information as well. You also want to find out about symptoms and concerns. So with this, it's about starting those conversations. So to help people feel at ease, you want to begin by explaining that some of the questions you're going to be asking are quite personal, but they are necessary to ensure that the medicine is right for them. You also want to consider using a mix of open-ended questions. That's going to engage people more, and it's also going to help you extract information better as well. Also, try and read body language. So if you can see the person's really uncomfortable, just try and keep them at ease as much as possible. So it's using that human approach. For example, you might want to ask open questions like, can you tell me more about what you're experiencing? Or how has this affected your intimate relationships? When did this problem begin? Was it abrupt or gradual? So it's a mix of open and closed. Then you would screen for risk factors and red flags. So for example, you would ask the person find out if they've got underlying risk factors. So discuss possible causes, contributing risk factors, address those issues. And, for example, you might give lifestyle advice there at that point. You want to find out about physical, psychological, and any side effects for potential medicines. You also want to find out if they've got any health or medical conditions and what medicines they're on, because you want to check for contraindications, interactions, and any reasons for referral. So again, the manufacturers usually have a really good checklist that you can use, but questions that you might consider asking, for example, are, I won't go through them all because there's so many to ask, but things like, do you or have you ever had a problem with your heart, like a heart attack or a stroke, etc.? Or, for example, do you feel very breathless or get chest pain when you walk fast for 20 minutes or when you climb 2 flights of stairs? So they're kind of typical questions that you might have to ask to make sure it's appropriate for them. Then you want to start recommending appropriate interventions. So, for example, you want to check whether the product you're supplying, whether they're hypersensitive to any of the active ingredients or excipients. And if they are, obviously they won't be able to take it. and also if they've had it before, so whether it's been prescribed or whether they've bought it over the counter before, to check whether, for example, they've had any side effects that you need to be aware of, whether there was improvement, whether it actually worked for them, whether there's been any changes since the last time they bought it or were supplied it, or whether they were refused supply, or whether they were asked to stop treatments. And then when you've done all of that, then you'll make that decision and then provide counselling. So next slide, please. So at this point, you'll need to use your professional judgment to decide on a suitable action. So you've got all the information you need, you've had your discussions. So if the supply is suitable and the person requesting the medicine is happy to continue, then provide counselling. And if the supply isn't suitable, or if you're in doubt of the suitability, or if they need investigations or medical attention, or another medicine might be suitable for them, that's when you need to refer to their healthcare professional or clinician. Next slide, please. And again, so now it's time to give the counselling, and you can apply this when you're prescribing, dispensing medicines, and also supplying it over the counter. So the type of counselling you'd need to give is, number one, advise them to read the patient information leaflet that's usually found inside the medicine box as well, as a reminder of any kind of key safety messages, and they can refer back to it if they've got any questions. So you want to discuss the following things. So the medicine, what it is, how it works, and how to use it, and the importance of adherence. Then the side effects and adverse effects of medicines, to make sure that they are aware what signs and symptoms to look out for and when to seek medical attention. Referrals, make sure the person knows when to see their clinician or their doctor, including for when they need to have reviews. Interactions, make sure the person knows to check interactions with a pharmacist before starting any new medicines, including to avoid grapefruit juice and also recreational drugs. Next slide, please. You also want to identify risk factors early on and share that information with them to encourage self-care, to improve quality of life, for example, to prevent any kind of future CV, cardiovascular events. Alcohol, advise them not to drink too much because that can affect sexual activity, and also the effects of the medicines on driving, that it can cause drowsiness or dizziness, more like. Health promotion, so where relevant, you want to provide lifestyle advice and well-being advice where appropriate. So that might be diet, exercise, smoking cessation, reducing alcohol, stress, weight, and blood pressure. But you'll identify this when you're having those conversations with the person as well. Next slide. Then you've got alternative treatments. So you want to provide information on alternative treatments, including non-pharmacological management and pharmacological management. So people should be made aware of all the treatment available options to them so that they can make an informed choice. Then you also want to explain the condition and what causes it, to empower the person to understand their condition better, and also offer any sexual health advice. So you might refer or signpost to services in your area. And then finally, further supply. So make sure the person knows how to obtain further supply. Okay, next slide, please. I won't go into too much detail because it's already been covered, but I think the main point here is just making sure that they know what the symptoms or side effects to look out for are, especially the ones that require the person to stop that medication and go and see their clinician or health practitioner. Next slide, please. And again, here's just a reminder of the interactions because it's already been covered, but I think what's really important here is to use your professional judgment to regularly check interactions with people and their concurrent medicines, like prescribed medicines, over-the-counter, herbal, complementary, vitamins, dietary supplements, recreational drugs, alcohol, tobacco, just in case they're of clinical relevance and need referral to the prescriber, because a lot of people are on supplements these days, so it's really important to cover everything. Next slide, please. Again, I might skip this one because it's already been covered, but again, it's just about making sure people know about the different options available to them. So next slide, please. And then again, this has already been mentioned, but I just wanted to give you a reminder of all the non-medication treatment options available in Great Britain that we have, that we also let the person know about as well. And next slide, please. And finally, these are some other considerations that you also might want to talk about. Sometimes we miss them, but actually they're very important. So see whether you need to keep any records of supplying. So for example, if you refuse a treatment, you might want to log that on their medication records so that you know for next time, or if another pharmacist comes in, they'll know. Make sure that you let people know about the risks of buying medicines online, especially if it's from unregulated sources as well. So that's something to have a conversation with people about. Then you've got storage and disposal. So make sure people know how to safely store their medicines and also how to dispose of them appropriately. So a lot of pharmacies accept old medication back so that they can destroy them properly and appropriately. Okay, next slide, please. So at this point, I really wanted to let you know about some of the implementation strategies that we've used in practice in the pharmacy to help people deliver this service. So number one, you want to educate your pharmacy team. So they're usually the first people that the public come into contact with. So make sure that you provide educational training resources for them and also the time to actually read it and digest it and understand it. It's really important to develop good communication skills for yourself as a pharmacist and also for your team as well. And that's going to help you initiate those conversations. So, example, you want to learn how to ask open questions. You want to learn to read body language. That's really going to help you. It's really important to understand that sometimes discussing ED symptoms can be really uncomfortable for some people because it's taboo or they're just embarrassed. So make sure that you are discreet, you are non-judgmental, and you put the person at ease whenever they're coming into the pharmacy. The ways that you could do that, for example, are making sure you have a private room for consultations. And also you might want to create like a gender neutral environment in the pharmacy. So you might have like a men's health section or something like that and have clear signage for that. You also could display leaflets and posters, maybe have campaigns or take part in campaigns, maybe have leaflets in different languages to help reach different audiences. And also make every contact count. So if you're doing other interventions and services like blood pressure, cholesterol checks, etc., then maybe start those discussions there. Just find out how they're doing and any other issues that they want to talk to you about. And also use available resources. The manufacturer product education materials are really, really good. They have checklists, as I mentioned. Sometimes they have patient leaflets and resources as well. And also try and diversify your workforce. People might feel more comfortable speaking to a male staff member. I know this isn't always possible, but they're just things that you might want to consider. But most importantly, take a person-centered, holistic approach and encourage the person also to get involved and understand their own condition as well and how they can help themselves. And then finally, I just wanted to, if you go on to the next slide, please. Just wanted to tell you about the lessons learned. So by Great Britain actually delivering these services, we found that it's improved access to medicines and care through the pharmacy. It's relieved pressure on general practice, so doctors' surgeries, because there's reduced waiting times or no waiting times within a pharmacy. Pharmacists are the trusted source of knowledge on healthcare and medicines. And the success of delivering these medicines has led to the delivery of further services to screen and treat other conditions like minor ailments and also contraceptives. And then more medicines also that are usually prescription only are now being reclassified to pharmacy only to improve access over the counter as long as they're safe. So yeah, thank you very much for that. I will, if you just go on to the next slide. I think I'll skip those other ones, but yeah, thank you very much. That's all from me. If you have any questions, I'm happy to take it, or if you'd like to contact me, here's my email address as well. Thank you very much for listening. I hope that's helped.
Regina, that's been more than helpful. That's been fantastic. Thank you for a very, very comprehensive overview of the services that are being offered to people in the in Great Britain. And thank you to you and to everybody at the Royal Pharmaceutical Society for taking the lead on this. A couple of questions that have come through, I think, have been answered in your presentation. And probably the other thing that I'd like to say as well is that this is a fantastic resource to show people who are regulators, people who create legislation and policy in whatever country you are in, that there are countries already where people are accessing and benefiting from these services already that we can example in order to get more of these essential pharmacy services to more and more people. Regina, you're very kind to share your email address with colleagues also, and I'm sure that plenty of them will take you up on your kind offer of making contact with you. So thank you again for your presentation. Our next part and our final part of the presentations is Erectile Dysfunction, a handbook for pharmacists on managing symptoms and supporting self-care. That's why we're here. So in order to make sure that we complement Inés Núñez de Cunha properly, for putting together a huge amount of work to make this happen and this webinar happen. I'd like to present her to you. So Ines is a practice development and transformation manager at the FIP. And before joining FIP, Ines worked as a community pharmacist for 14 years and then spent 6 years teaching at the university level as a professor in the Integrated Masters in Pharmaceutical Sciences in Portugal. She holds a master's degree in pharmaceutical care and a PhD in pharmacy, specializing in social pharmacy from the University of Granada in Spain. With that, ladies and gentlemen, because time is tight, I am going to hand over to Ines and thank her again for all her hard work in making this happen.
Thank you very much, Daragh, for your kind words, and good afternoon, everyone. Let me begin my presentation by thanking our excellent speakers for their insightful contributions, all of whom were involved in the development of this publication, either as co-authors or reviewers. And their expertise and collaboration has brought this handbook to life, and I am super happy today, and I'm truly grateful to them. So it is my pleasure to present to you today the new FIP publication, Erectile Dysfunction, Handbook for Pharmacists on Managing Symptoms and Supporting Self-Care. This resource has been developed under the FIP Practice Transformation Program on Non-Communicable Diseases, and it aims to support pharmacists in delivering high-quality, people-centered care to men affected by erectile dysfunction. And you can access the full publication using the QR code on screen or through the FIP NCD's microsite at ncd.fip.org. Building on what we have heard in previous presentations, it's clear that erectile dysfunction is more than just a physical issue. It can affect emotional well-being, self-esteem, relationships, and overall quality of life. So it may also be a marker for more serious underlying conditions such as diabetes or cardiovascular diseases. And pharmacists are highly accessible and trusted healthcare professionals who are ideal placed to support men affected by ED. Through everyday interactions, pharmacists can help identify erectile dysfunction at an early stage, offer effective management options, and refer when needed. So this handbook was developed to equip pharmacists with practical tools and evidence-based guidance to provide both pharmacological and non-pharmacological supports. It encourages a people-centered approach and highlights the importance of interprofessional collaboration. By improving pharmacists' knowledge and confidence in this area, we aim to help break the silence and stigma surrounding this condition and empower pharmacists to play a more active role in supporting men's health. The handbook is structured into several chapters, offering pharmacists a clear and practical framework for managing erectile dysfunction. It explores a range of key topics from understanding causes and risk factors to addressing both pharmacological and non-pharmacological treatment options. Importantly, it highlights the pharmacist's role in supporting men's health more broadly, either by recognizing red flags, advising on medication use and side effects, or promoting healthy lifestyle changes. You will also find practical tools such as communication strategies for approaching sensitive conversations and guidance on when referral to other healthcare professions may be needed. Overall, the content is designed to help pharmacists integrate these approaches into daily practice and provide holistic, people-centered care. Building on the people-centered approach, the handbook focuses on how pharmacists can translate this into concrete actions in daily practice. It outlines practical ways to support men affected by ED, from facilitating convenient and timely access to treatment, including over-the-counter options where permitted, to screening for risk factors and underlying health conditions that may be contributing to erectile dysfunction. The handbook also reinforced the value of medication reviews to optimize treatment and minimize adverse effects, while encourage support for self-care through evidence-based lifestyle changes such as physical activity and tobacco cessation, for example. Crucially, it provides guidance on how to engage in open, non-judgmental conversations, helping ensure that men receive the most appropriate and comprehensive care they need. To conclude, this handbook empowers pharmacists to take a more proactive role in supporting men affected by erectile dysfunction. By equipping pharmacists with the tools to provide people-centered care and promote early intervention, this research reaffirms FIP commitment to advancing pharmacy practice and improving health outcomes in men's health worldwide. And we hope you find it a valuable resource to apply in your daily practice and a step towards breaking down the barriers many men face when seeking support. Before concluding my presentation, I just want to acknowledge all of those who have contributed to the development of this publication. FIP is especially grateful to the members of the advisory group, whose names are listed on the slide, for their valuable input, review, and insightful suggestions throughout the development process of this publication. And we encourage pharmacists from around the globe to explore the handbook and reflect on how its guidance can help strengthen their contribution to men's health through pharmacy practice. So thank you very much.
Inez, congratulations on getting through a whole lot of information very, very quickly there. And I know that everybody who's joining us today, whether it's live or whether it's later on, will be very excited to read the handbook. So congratulations to you and the team and to everybody who contributed, particularly those people mentioned on the editing section. It was fantastic. We're out of time. It's 31 minutes past the hour, but what I'm really glad to see as moderator is that the vast majority of questions have already been answered. So I want to thank the contributors who took the time during the presentation to answer the questions. And I know that some of the questions that were asked were then subsequently answered within the sections, particularly from Brad and particularly from Regina as well as time went by. So with that in mind, I want to thank you for your participation today, colleagues, ladies and gentlemen. And what I want to say is that there are lots of resources available to you as pharmaceutical scientists and pharmacists around the world. But the best way to do that is to become part of the FIP family, not just be an observer, but be a participant, meet other pharmacists and scientists who share your passion for pharmacy and for fantastic person-centered care. And the way to do that is by becoming a member of FIP. If we could advance the slides on, I want to let you know that we have other FIP events that you can log into and look at them retrospectively. And they're there for you. Again, best way to do that is by being a member of FIP. And then, last but by no means least, the pinnacle, the Pharmacy Olympics, if you will, is the FIP World Congress, where the whole family of pharmacists and pharmaceutical scientists from around the world come together once a year. And this year, we will celebrate our World Congress of Pharmacy and Pharmaceutical Sciences in Copenhagen, Denmark. There is still some availability for people to attend, and I would ask you to consider going. I would ask you to consider contributing. We have the theme of making it a sustainable practice, making the systems work, and then making sure that we are making healthcare personal. There's an early registration which goes until the 2nd of June 2025, and then the second registration deadline runs until the 11th of August 2025. Ladies and gentlemen, it's just a little bit past the half hour. I want to thank you for your attention. I particularly want to thank Ines, Regina, Brad, Pablo, and Gerald for being fantastic contributors for a lot of work that has gone on here. And I very much appreciate all the love hearts and claps that are going up that I can see from the emojis. We had over 200 people participating today in this webinar, and I think it's a testimony to the important work that pharmacists do, but the important work that pharmacists can do around the world. So with that, enjoy the rest of your day. Thank you for your attention and thank you for your time. And please consider becoming a member of FIP.